Alrighty, everybody, another episode of Daily Doc Talk. It has been quite some time since I did one of these episodes, kind of the longer form, talking about a particular topic, but I have wanted to talk a bit more, and so deciding to do 66 days straight of filming for Daily Doc Talk. So we'll actually get back into a Daily Doc Talk. Today I want to talk about neurogenic inflammation and how this is an area of pain that is not really talked about a lot outside of like these niche circles for people who evaluate and treat neurogenic inflammation. And the first layer to that is obviously if you are out there and you're like, oh, this sounds like me, I think I have neurogenic inflammation and I want to get treatment for it, like where do I go, what do I do, like how do I convince my doctor to do this procedure? You're not going to convince your doctor. The doctor who doesn't actually know about this and doesn't do anything about this is not going to all of a sudden just be like, oh, this patient asked me to do this injection procedure and insurance doesn't cover it, insurance doesn't even know what it is, so let's do it. That's not going to happen. So if you think that you have chronic neurogenic inflammation or you want to be evaluated to find out if you do or if you don't, you have to seek out a doctor that actively knows about this. So look on social media, find somebody who talks about it, look on websites, search perineural injection therapy, nerve hydrodissection, neurogenic inflammation, doctor, physician, whatever in your area, and find somebody who actually talks about this in order to get an evaluation for that. So the particular case that I wanted to talk about was a patient that I had on our student rotation. Patient had unilateral knee pain that was on the medial side. She had sustained an injury, basically kind of like a minor compression injury. So something hit her on the inside of the knee. And ever since then, she's had this medial knee pain and no one's really been able to do much about it. We did obviously in-depth history, physical exam. I also did an ultrasound evaluation because I was curious to see what was going on, even though I had already kind of suspected that what we most likely had was some neurogenic inflammation. But an ultrasound evaluation just to also teach the students that we can have these changes on imaging that don't necessarily equate to pain. And so on our ultrasound for the medial aspect of the knee, we obviously looked at the MCL, we looked at the medial meniscus, we looked at the bone, so obviously our femur and our tibia, because that can give us some insight into if there's osteoarthritis, if you've got major bone spurring, anything like that, loss of joint space, and then also for the meniscotibial or the coronary ligaments that attach the meniscus down onto the tibial plateau. And this patient looked like definitely some arthritis, so there was some pretty significant bone spurring in the area. The MCL looked fine. There was a little bit of area that had some edema in it, so probably a mild sprain of the MCL. The meniscus was extruded, which essentially means that it was bulging out past the level of the tibial plateau, which usually means a meniscotibial or coronary ligament injury. And the coronary ligaments on that side all swollen. They most likely had some tears in it. So the whole medial aspect of the knee from an imaging standpoint was just awful. But almost none of those things were actually positive on physical exam. So all of our meniscus tests, negative. Doesn't seem like any of this pain is coming from the meniscus. Our test for the MCL didn't really, recreate any of her pain. The only thing that recreated pain was palpation of the inside of the knee joint. Now, the other things for her case characteristic of neurogenic inflammation is pain basically goes completely away when she is rested. It comes on when she's active. So if she's walking, going upstairs, or doing any type of activity, exercise activity, but then as soon as she stops, it goes away. It doesn't linger for a long period of time. And that's very, very characteristic of neurogenic inflammation. And so also under ultrasound guidance, we took a look and we found the infrapatellar branch of the saphenous nerve, which was definitely a little bit enlarged, and we could palpate and feel that, which also generally means that it's inflamed. That also correlated with her tenderness. And so these are the things that we're trying to do during our physical exam is we're trying to take the history portion. So she had a direct injury, not like a valgus injury where the inside of her knee went inwards or anything like that, but she was hit with something on the inside of the knee, which often irritates nerves. The pain got worse with activity, better with rest. Then we layer in the physical exam. It doesn't seem like anything major structural is causing her pain. She doesn't have any physical exam signs that would indicate that a lot of her pain is coming from osteoarthritis, from the meniscus, from the MCL, even from the coronary ligaments. And then imaging, which didn't actually tell us much. It told us a lot, but it did not fit in with the case, except for the larger than average infrapatellar branch of saphenous nerve that correlated with, when we pushed on that, it was painful. And so from there we did perineural injection therapy. Sometimes we will go and we'll do a nerve hydrodissection of the larger saphenous nerve before it gives off the branch for the infrapatellar branch of saphenous. But we performed a perineural injection therapy simply with 5% dextrose to hopefully calm down that inflammation. Patient felt better immediately after the procedure, which sometimes we have that and then the pain relief doesn't last, but we will follow up a few weeks with her to see how it is. But this is a pretty clear-cut case of neurogenic inflammation that has gone unnoticed, unrecognized, undiagnosed, because a lot of the conventional medical field doesn't really pay attention to these types of pain, these types of injuries. So that is our first day of coming back with Daily Doc Talk. See y'all later.